but I think Jorge, oh, he's here. Okay, my question is kind of a comment, but I'm interested in your views. Now, over the years, I have seen personally that many people for inguinals are placing the camera port just above the umbilicus and then putting midline ports and doing the same old TEP operation and calling it ETEP. Some people are putting it laterally on a unilateral hernia contralaterally and dissecting the opposite side and calling it ETEP. I personally think these should be called METEP because there is a potential for confusing what you conceived of as the ETEP operation. But given that there is a versatility in the port placement in ETEP, how would you say that these procedures come in vis-a-vis the one that you have described and which most people tend to follow? So would these be kind of variants, or how do you classify these, or how do you place these alternative approaches to MIS inguinals? Is my question clear?
Thank you. It's a great question. Well, I would say only time really baptize and even consider what the importance of a technique is. So surgeons are great innovators. As soon as you show them something, they are modifying the things. So you cannot stop that. You have to accept that. I have accepted that. And I think the variety is going to be more uniform with time. And probably they will notice that by trying, we have found this the best way to do it above the umbilicus. That also gives them the first glance of the ETEP for incisional and probably for lumbar hernias and other procedures. So it's only a time. I wouldn't put a name to those. The same way I didn't put a new name for ETEP. I just add a TEP just to make Philip mad about that, because he's always fighting to me. What is it? Is it hands? Is it expanded? What is that? So there is no reason to name every variation with your own technique as you are seeing in all the publications. Time will tell. That's my answer.
Can I? Yeah. Thank you, all of you, for excellent talks. I have a question for David and I have a question for Jan. David, can you just quickly comment, when do you do pragmatic neurectomy? When you do Liechtenstein? So what is an indication to do that? Because this is a question I come across when I do workshops and things, and actually I don't have a really good answer. Maybe you have a better one. And Jan, can you comment on when do you use heavy meshes in TAPP repair? Because that has been discussed in the last couple of months.
So pragmatic neurectomy, I would say that you do a pragmatic neurectomy if you have to. So if you have a nerve like I showed you that has too many branches, so your mesh will never sit, you will never sit there without touching too many of those nerves, you'll see the most common things to do a pragmatic neurectomy, that multiple branches, ilioinguinal nerve that then cuts away from the cord. So normally it will run right on the cord. Sometimes you'll see it will break medial or lateral. Then you know that if you're fixating your mesh, it will be put under tension. Iliohypogastric, sometimes that it will cut the field. Sometimes you can make a little slit in your mesh, a little notch in your mesh, and if that sits fine and it doesn't cut the nerve, that's fine. But sometimes if it really kind of takes a trajectory that the mesh and the nerve will just be in apposition, just take that nerve. It's not worth it.
Well, thank you for the question, Henry. It's, I think it's important. We have so many different meshes, and when we get the information about each polypropylene, said, well, there are about 300 different polypropylene meshes. So the name gives it the property, the porosity, and I think that the question goes there. When I have to deal with M3 hernias, I expect that the mesh could prolapse into the defect. First, I want to make it flat. That means I retract the transversalis fascia and suture it to the rectus, just to make it flat, not to close the hole, not to close the defect. please. It would not be tension-free. And the second, then I would take a heavier mesh, more rigid, because especially for the endoscopic techniques, it does not make the foreign body feelings. I would not use that mesh maybe for Liechtenstein, but for TAPP is absolutely perfect, and one can give it a name. I don't want to make any propaganda for that, but we have, for example, the visible meshes, or PVDF meshes, which are absolute best choice for this. They are stiffer, they are bigger, they are controllable, because you can make an MRI if there should be anything wrong in the course.
I think the other place for heavyweight mesh, though, is the lumbar, the flank hernias. I think it's important to use a heavier weight mesh in those constructs, especially because a lot of those hernias will have a denervation component as well. So heavyweight mesh for that.
For sure, the most important condition being the porosity. I have a question for you all regarding the etiology of chronic pain. How much is part of the surgeon? How much is part of the access? And how much is part of the mesh?
The expert here is Dr. Chen, but I will say that, in my view, the most important factor is the surgeon. For sure, because you see the individual differences. So when experts publish, the rate of chronic pain is negligible, while when non-experts do it, or they are referred to experts, they notice who is the champion of chronic pain. So there is an individual factor. Of course, there must be some luck factor also, because if the nerve is in the wrong place, well, you probably hit it. But that shouldn't be the rule.
Yeah, I always say that it's important to just remember that the number will never go to zero. You know, even if you have experts doing it, you're always going to have that one person that just has, like, where whatever happened, you know, the anatomy is different. So that's why I never throw stones at anyone. But when we look at, you know, I've seen over 3,000 patients for pain, and I've operated on about a little over almost 800 now. And when we look at it, there's so many patients that it was preventable, right? That you saw that it was bad technique, that the mesh was folded because it wasn't dissected well, that there's 35 tacks in the groin from an inguinal. You know, it's like you had to take a whole stapler and then get another one, you know? So there are things that if we could prevent all of the technical things, surgeon-related, then the number goes way down. And if you have every once in a while someone feels their mesh because it's heavier weight, or they have some, you know, fibrosis or whatever, fine, we accept that. But we just want to have where even one is too many if it was avoidable.
Well, I would still agree on that. It's the surgeon, because surgeon decides which kind of mesh. The surgeon decides whether he needs 2 or 3 tackers or whatever. It's a wrong decision, wrong performance. This is absolutely it, because I recorded all my TAPPs since 1992, full length. So I can go back, and we've learned very early that we have to increase the size of the mesh, that we have to do this, that the dissection has to be much more gentle. All about that, what you heard today about landing zone. This is the technique. And that's why it's the surgeon, it's not the mesh.
Thank you so much. The last question, Manuel.
Thank you. I am Manuel López Cano from Barcelona in Spain. And I have a question, because every time I attend a meeting or a panel regarding inguinal hernia and different techniques, I miss a lot of times, and every time, a talk or comments regarding open preperitoneal approach for the repair of an inguinal hernia. And I think it's a fantastic technique. Even if you don't have access to a laparoscopic instruments, you can place the mesh in the preparatory space. For me, it's the best space to place a mesh in the repair of an inguinal hernia. And there is a total lack of teaching about this technique in the different program, residency programs, and so on. What do you think about this technique, and what is the reason for you that this lack of comments about this fantastic technique?
Yeah, you know, I think that the beauty of preperitoneal open repairs is that, all of the benefits from a Liechtenstein are there. The open, local anesthesia, low risk, and you get the benefits of mesh in the ideal position, right? So there's definitely positives to that. I think, honestly, the problem with open preperitoneal repair is that nobody can teach it well because so much of it is based on faith. When you looked at these live surgeries of like Ugari repair and doing these great tip operations, and then you feel here and the mesh is perfect and and it's perfect. You don't see anything, right? And so you then try to teach somebody to do that. It's like, whatever, that. So what happens is people just shove in mesh, and the problem is that I see so many patients that have pain problems, and if you think about preperitoneal repair, for all the reasons why David Laurier and Johan showed you the anatomy, it's the wrong access to get to the preperitoneal space because it puts you so many times in the pretransversalis plane. When people have problems, I'll see that, I go in laparoscopically and we see the meshes above the epigastric and it's folded so it can never really deploy. So the problem of an open tip repair is that it's hard to make that pocket open if you're not good at it. When you're good at it, it's perfect. But it's hard to teach a resident, and it's hard when you say look under the corner, as opposed to when you do it laparoscopically or robotically. The field is so big, and we're constantly telling people make the field bigger so that you could see the wider mesh. So I do think it's a great repair. I think that if you adopted it and you learn it well, it's great for your patients. I just think that if you're talking about why did Liechtenstein become so common? Because it was easy, right? You have to make surgery easy.
Yeah. I was trained under Nihus, not under Nihus, but I was trained in Nihus technique, preperitoneal, and that was our go-to inguinal hernia repair. And one of the advantages of this approach is for incarcerated hernias. When you suspect the bowel is compromised, I still, that's my go-to procedure for incarcerated patient with obstruction because you can solve both sides of the problem.
That's the key, Jorge. But David, you are doing, in my opinion, a mistake, very common mistake, is the confusing an anterior approach of the preperitoneal space, like TIP or TEP or TREP, or as you know, are a pure posterior preperitoneal approach that is totally different. You can see all the myopectineal orifice. I am speaking about, for example, about the wand technique, it's totally different. It's totally different, and it allows us, as Jorge said, to solve a lot of problems in emergency settings, doing like a mini laparotomy, opening the...
A stopa, and that's the thing, is to do a unilateral stopa, Reeves or a Wantz operation. It's a great operation, but to come from a midline. It's just, I think that nobody wants to have a midline incision.
No. Again, I invite you to my hospital. We have experience with
I think
unilateral
we need
incision.
stopper here.